Welcome to today's Explainer, where we're tackling a topic with incredibly high stakes: pediatric medication administration. Now, if you've ever looked at a tiny infant and wondered how on earth doctors and nurses figure out exactly how much medicine to give them, well, you're looking at one of the absolute most complex, precise, and unforgiving areas of modern healthcare. Today, we're going to unpack the whole shebang: the science, the psychology, and the extreme precision it takes to keep our youngest, most vulnerable patients safe.
Here's a quick look at our agenda for today. We're going to cover high stakes, pediatric guidelines, age-based interventions, oral medication, the IV route and safety, specialized routes, and we'll wrap up with advanced dose definitions. Let's get to it.
All right, Section 1, High Stakes, Pediatric Guidelines.
So, giving medications to children, it is an incredibly serious responsibility. It's really not just a routine task. It's honestly a high-wire balancing act. The big question is, are children just small adults? It's a super common misconception, right? You might think, well, if a grown adult gets 100 milligrams, a kid who is a tenth of the size should just get 10 milligrams. We need to completely shatter that idea right now. Pediatric dosing is absolutely not just adult dosing scaled down on a calculator.
To really understand why, we have to think about the physiological differences. Think about an adult's organs, specifically their liver and kidneys. They're mature. They process and flush out drugs at a highly predictable standard rate. But a child's organs? That's a totally different story. A kid's liver, which handles breaking down the drug, and their kidneys, which handle getting rid of it, are immature. Because these organs are essentially still under construction, drug breakdown is sluggish. This means drugs can dangerously pile up in their bodies, leading to severe toxicity if the dose isn't meticulously adjusted.
And this is exactly why the math is so high stakes. Small errors literally lead to major harm because of those immature organs. In an adult, a tiny calculation error might just make them a bit drowsy. But in a small child, with their low body weight and tiny distribution space for the drug, that exact same math error can lead to profound organ damage, or even be life-threatening. The margin for error is razor thin.
Which brings us to a fact that honestly blew my mind when I was reviewing the source material. Fully 50% of all medications on the market today do not actually have a documented safe use in children. Why? Well, drugs are primarily tested on adults because of the obvious ethical limitations of running clinical trials on kids. So healthcare providers are very frequently using drugs off-label in pediatrics. We're dealing with limited safety data, and that demands extreme vigilance and strict adherence to guidelines from every single nurse and doctor.
Moving right along to Section 2, Age-based nursing interventions.
Okay, so now that we understand the physical immaturity of a child's body, we have to look at the psychological side of things. A child's developmental stage completely dictates how we deliver their care. Just think about how administration techniques have to evolve as a kid grows. For a toddler who really only grasps basic concepts, we use simple words and a firm approach, and we rely heavily on distraction. But move up to a preschooler and suddenly giving them choices like, hey, do you want apple juice or grape juice after your medicine? Or giving them a brightly colored Band-Aid builds this incredible emotional comfort. By the time they're school age, they need honest explanations. This is where medical play, like using toys to demonstrate a procedure, really shines. It lowers their fear, cuts down on behavioral resistance, and builds crucial trust.
But, regardless of the age, there is one absolute universal rule we have to enforce, both in the hospital and at home. Do not call medication candy. I know, it seems like an innocent parenting trick to get a fussy toddler to take their cough syrup, right? But this is a massive safety trap. Kids are naturally curious, and calling medicine candy creates a really dangerous misconception. If they find that bottle later, they might think it's perfectly safe to eat freely, and that right there is a leading cause of accidental pediatric poisonings.
Section 3, Oral Medication Administration.
So, the GI tract is awesome at absorbing drugs, but getting an infant or a tiny child to actually swallow medicine without spitting it out or choking, that is a serious clinical skill. For infants, the technique is super specific. First, you apply gentle chin depression to get the mouth open safely without causing any trauma. Second, and this is absolutely key, you direct the oral syringe toward the inner cheek, which is also called the buccal side. Why do we do that? Because shooting it straight to the back of the throat can trigger the gag reflex, or worse, cause the drug to go into their lungs. The inner cheek prevents aspiration. Finally, you release it slowly. Infants just can't coordinate swallowing and breathing all that well, so a slow release prevents choking and vomiting.
And if you're trying to hide a medication that tastes absolutely awful, the volume we mix it into matters immensely.
Mixing the drug with a small amount of food, like a spoonful of applesauce, is best because you know for sure the child is going to eat the full dose. But you should never ever mix it into a full bottle of formula. If the kid falls asleep or just loses their appetite halfway through that bottle, they've only gotten half their medicine. And worse, you have no idea exactly how much they actually ingested. It's a major clinical mistake.
Let's shift gears to Section 4, IV route and safety. If oral meds are tricky, intravenous medications are intense. We're bypassing the digestive system entirely and putting the drug directly into the child's vulnerable vascular system. The effects are instant. Now, I want you to focus on this critical window of 3 to 5 minutes. When administering powerful IV push drugs to a child, we're talking heavy hitters like morphine, Solumedrol, or Lasix, they have to be pushed slowly over this precise time frame. If you push these too fast, a child's small body can suffer from what's called speed shock. It's a toxic, system-wide reaction that can literally cause sudden cardiac arrest. So patience here literally saves lives.
Here are the essential guardrails for pediatric IV safety. You absolutely must supervise administration. Always check if the drugs are chemically compatible, and flush the line between doses to avoid dangerous interactions happening right there in the tubing. And I really want to highlight the fourth point: dilute using albuterol. Albuterol is this special IV chamber that measures and dilutes fluids before they ever enter the child's bloodstream. It's basically the ultimate mechanical safeguard to prevent fluid overload, which a small child's heart and lungs simply cannot handle. Finally, you've got to monitor that IV site hourly, because complications can escalate incredibly fast.
Section 5. Specialized Administration Routes.
Okay, so what happens when a kid can't take a drug orally and they don't have an IV set up? Let's take a quick look at these specialized routes. First up, intramuscular, or IM injections. You might actually be surprised to hear this, but these are rarely used in the acute hospital setting for kids because of the pain and trauma they cause. For eye drops, you gently pull the lower lid down to create a little sac, strictly avoiding touching the cornea itself. Nose drops require the child's head to be hyperextended, so the medicine doesn't just immediately drain right back out. But the really fascinating one here is the rectal route. Because the rectum has such a rich blood supply, it is a brilliant backdoor into the circulatory system when a child is constantly vomiting and just can't keep an oral pill down. It is highly effective for things like sedatives and anti-nausea medications.
And finally, Section 6, Advanced Pediatric Dose Definitions.
Now don't let the word definitions put you to sleep. These aren't just boring textbook terms to memorize. These are literally the mathematical safety nets of pediatric care. First up is the usual pediatric dose. This is the standard, research-based amount that safely produces the medicinal effect in an infant or child. Remember, because of that immature liver enzyme activity we talked about earlier, the exact same drug is going to have a radically different effect in a child than an adult. So this usual dose is our starting baseline, strictly tailored to their specific age and weight.
The fundamental concept of a dose is the exact amount of a drug needed for a therapeutic effect, and this precise number exists on a razor's edge. Giving exactly this amount prevents two really dangerous extremes. On one side, you have underdosing, which means the treatment fails and the child just stays sick. And on the other side, you have overdosing, which leads directly to toxicity.
So how do we maintain that perfect amount over time? That's what we call the dosage regimen. This is the schedule of drug timing and duration. It's not just about how much medicine you give, but when you give it. Sticking to this precise schedule ensures a consistent therapeutic effect. It basically means the drug stays active in the body, doing its job without dangerously piling up inside those immature kidneys. And finally, the minimum effective concentration. This is exactly what it sounds like, the lowest blood level needed to actually do anything helpful for the patient. This is the absolute baseline target for nurses and pharmacists when they're calculating a child's medication. If you fall below this line, you are essentially just giving the child flavored water. So, we've covered the immaturity of a child's organs, the psychology of gaining their trust, the precise mechanics of IV safeguards like the albuterol, and the incredibly strict definitions that govern their dosages. It all brings us to one final vital thought. If a small calculation error, like just putting a decimal point in the wrong place, can cause major, life-threatening harm, are we doing enough to protect our most vulnerable patients? It's a question that demands deep respect for the sheer complexity and precision required in pediatric medicine every single day. Thanks for joining me for this explainer. I really hope it transformed how you view pediatric care. Catch you next time.